Good morning, I am Dr. Seema and today we will learn about Inguinal Canal. Specific learning objectives of today's class. At the end of the class, students should be able to define the location, extent, boundaries and contents of Inguinal Canal, define the boundaries of Hasselbecks triangle. Before going to the topic directly, we will refresh few previous topics which are very essential to understand the current topic. Now this is a diagram of Boney pelvis which is formed of two hip bones, one sacrum and one coccyx. And here give more attention towards the hip bone. It is formed of three parts. The expanded upper part is called as the ilium and this antero-inferior part is called as the pubis and this posterior-inferior part is called as the ischium. Now see the pubic bone. It is having a body and two rami. This is the superior ramus and this is the inferior ramus. Now the body of the two hip bones are forming a joint in the midline which is called as the pubic symphysis. This is the enlarged view of the bony pelvis. Now what you are seeing here is the body of pubis and this is the symphysis pubis. So the upper border of the body of the pubis is called as the pubic crest and the pubic crest ends in a tubercle which is called as the pubic tubercle. Now this is the superior ramus of the pubis and the margin what you are seeing is the pecten pubis or pectineal line of pubis which is the superior border of the superior ramus of pubis. And this is the iliopubic eminence which is a junction of pubis and ilium. Now this is the ilium and this part is the iliac crest and the anterior end of the iliac crest is called as the anterior superior iliac spine. So once more I remind you of all the important landmarks which you have to remember. This is the anterior superior iliac spine which is the anterior end of iliac crest. And this is the pubic crest which is the upper border of the body of pubis and this is the pubic tubercle which is the lateral limit of the pubic crest which ends in a tubercle and this is the pecten pubis or pectineal line of pubis which is the upper border of the superior ramus of pubis. Inguinal region or groin is the junction between anterior abdominal wall and the anterior aspect of the thigh. This region is very important as it acts as the exit or entry point to all the structures which has to enter or leave the abdominal cavity. And this is one of the potential site for the abdominal herniation. There are two important structures which are placed over here. One is the inguinal ligament and next one is the inguinal canal. Now we will see the layers of the anterior abdominal wall and inguinal ligament which mainly forms the boundaries of the inguinal canal. Now this is the anterior view of the abdominal wall and what you see here the skin and deep to that what you are seeing is the superficial fascia. Then comes all the three muscles of the anterior abdominal wall. To have a better idea we will just see the sagittal section of the anterior abdominal wall. The anteriormost layer, this is the skin. Deep to that what you are seeing is a superficial fascia and hope you remember below the umbilicus the superficial fascia will be divided into two parts. The superficial one will be the fatty layer which is called as a cambers layer and deep to that what you get is the scarpous layer or the membranous layer of the superficial fascia. So then skin, deep to that two layers of the superficial fascia, then deep to that you get the external oblique muscle first. Deep to that is the internal oblique. Still deep to that you have the transversus abdominis muscle. Then deep to that it is the fascia transversalis. Deep to that it is the extraperitoneal connective tissue and the innermost layer comes that is the peritoneum. Now one more thing I just want you to remember that is about the inguinal ligament. Now here if you see this is the first muscle, superficial muscle is the external oblique muscle and it will be forming towards the midline, it will be forming its aponeurosis and the lower part of the aponeurosis will be folding on itself and thickened to form the inguinal ligament. So in this sagittal section, if you see, this is the external oblique muscle and it forms the aponeurosis in the midline. So the lower part of the aponeurosis will be folding on itself, and this is that fold, and folds and thickens and folds on itself backwards to form the inguinal ligament. Now to see, this is the inguinal canal. You can see it's a content also, and you can see here it's almost all its boundaries are formed by the layers of the anterior abdominal wall and the inguinal ligament. Now we'll see a few extensions of the inguinal ligament too. This is the inguinal ligament which extends from the anterior superior iliac spine to the pubic tubercle, and which is the lower thickened part of the aponeurosis of external oblique muscle. And you can see here, this is the external oblique muscle, this is the aponeurosis, and this is the lower thickened part which has folded on itself. So this is the inguinal ligament. Okay, so very clear, this is the inguinal ligament. Now we'll see two extensions of the inguinal ligament here. This is the medial end of the inguinal ligament, and you can see that some fibers from the medial end runs upwards and medially in front of the rectus abdominis muscle, and it reaches the linea alba. This is the linea alba, which is a fibrous raphe which separates the two rectus abdominis muscle. So this part of the inguinal ligament is called as a reflected part of the inguinal ligament. Now from the medial end of the inguinal ligament itself, few fibers are moving backwards and medially, and which is getting attached to the medial end of the pecten pubis, and these fibers are called as a lacunar ligament. So this is the inguinal ligament. This fiber is a reflected part of the inguinal ligament, and this extension is the lacunar ligament. This is the posterior view of the inguinal ligament. You can see here, this is the body of pubis, posterior aspect, and this is the rectus abdominis, and even you can see that the rectus sheath is absent in the lower part. So this is a posterior view. Okay, and this is the inguinal ligament, and here you can very clearly see the lacunar ligament. So this is the medial end of the inguinal ligament, and you can see some fibers are extending backwards and towards medially towards the medial end of the pecten pubis, and this triangular fiber extension of the inguinal ligament is called lacunar ligament, and you can see that the apex of the lacunar ligament is towards the pubic tubercle and its base is broader. Now I want you to be familiar with 2 points. One is the midpoint of the inguinal ligament and other one is the mid-inguinal point. Midpoint of the inguinal ligament is the middle of the inguinal ligament which extends from anterior superior iliac spine to pubic tubercle. Now what is this mid-inguinal point? It is a midpoint of an imaginary line which joins anterior superior iliac spine to the symphysis pubis. The male gonad testis is developed in the abdominal cavity, and the inguinal canal forms the pathway for the testis to descend through the abdominal wall into the scrotum in the intrauterine life. Though at the time of birth most of the space is getting obliterated, it still remains a potential site for the abdominal herniation. That means for a site through which the abdominal viscera, especially the intestine, can protrude to the exterior. Now we will see our real topic, inguinal canal. Inguinal canal is an oblique intermuscular passage in the lower part of the anterior abdominal wall, just above and parallel to the medial half of the inguinal ligament. It extends from deep inguinal ring to the superficial inguinal ring. It is about 4 cm long and it is directed downwards, forwards and medially. Superficial inguinal ring is a triangular gap in the upper neurosis of external oblique aponeurosis, and it lies above and lateral to the pubic tubercle. The pubic crest forms the base of the triangle and it is having two sides, the upper or medial margin or lower or lateral margin. And these two margins are referred as crura, and these two crura meet laterally to form the apex. Near the apex, the two crura are united by intercrural fibers. It is almost 2.5 cm long and it is 1.2 cm broad at the base. The deep inguinal ring is an oval opening in the fascia transversalis and it lies about 1.25 cm above the mid-inguinal point. Now we will see the contents of inguinal canal. In male, it consists of spermatic cord and ilioinguinal nerve, and in female, it consists of round ligament of uterus and ilioinguinal nerve. So, ilioinguinal nerve is a common content in male as well as in female. Spermatic cord is a cord-like structure which suspends the testis in the scrotum. And as it can come as a short note, the structure of spermatic cord will be discussed in the next class. But one thing I want all of you to remember, that any structure which enter directly or indirectly into the inguinal canal will be deriving some fascia around it from the structures through which traverses through. For example, when it passes fascia transversalis, it derives a fascia which is called as the internal spermatic fascia. Then next layer, when it passes through the internal oblique and a few fibers of transversus abdominis muscle, it derives a fascia which is called as the cremastric fascia. And when it passes through the last layer, that is the external oblique aponeurosis muscle, it derives one more fascia, the outerwards, that is the external spermatic fascia. As the boundaries of inguinal canal are very important, first we will see the schematic representation of the same. Now this diagram represents the inguinal canal of the right side. Now this is the medial end and this is the lateral end. Now we can see that the inguinal canal is having an anterior wall, a posterior wall, a roof and a floor. Now you can see the superficial inguinal ring which is placed in the anterior wall of the inguinal canal, and here you can see the deep inguinal ring which is placed in the posterior wall of the inguinal canal. This is the same diagram of the right inguinal canal where the roof is removed so that you can see the posterior wall clearly with the deep inguinal ring, and even the content of the inguinal canal is represented, that is a spermatic cord. You can see it is coming through the deep inguinal ring and it is going out through the superficial inguinal ring. This diagram represents the anterior wall of the inguinal canal. Throughout its extent, it is formed by skin, superficial fascia and deep to that by external oblique aponeurosis. Now you can see the lateral half of the anterior wall is formed by a muscle which is the internal oblique abdominis. Now you can see one more muscle lateral to that, that is transversus abdominis, but it is not included as a content of anterior wall of inguinal canal. Now you may have the question, why? I have the answer for you. Both internal oblique abdominis and transverse abdominis arises from the inguinal ligament, but internal oblique arises from the lateral 2/3 of the inguinal ligament, whereas transversus abdominis arises from the lateral 1/3 of the inguinal ligament. And our inguinal canal is extending only up to the medial half of the inguinal ligament. So the transversus abdominis is placed too lateral so that it cannot form the anterior wall. Now we'll see the roof of inguinal canal. I hope all of you remember the origin and insertion of anterior abdominal wall muscles. Maybe you remember the internal oblique as well as the transverse abdominis muscle is having an origin from the inguinal ligament, and though they have different origin and insertion, the fibers which are arising from the inguinal ligament will be arching backwards, downwards and medially and form a common tendon which is called as the conjoint tendon. And now you can see that from the anterior wall these muscles which are arching, the fibers which are arching backwards, downwards and medially is forming the roof of the inguinal canal. This is the inguinal canal and you can see the fibers which are arching downwards, backwards and medially. And these arching fibers are mainly forming the roof of inguinal canal. Now to see that the muscles, both of the muscles together is forming a common tendon, and you can see its location is near the medial end of the posterior wall. So the internal oblique muscle is especially having a three-way relation to the inguinal canal. It forms the anterior wall, roof and a part of the posterior wall. This is the posterior wall of inguinal canal. Now you can see this. This is the fascia transversalis and you can see the opening. This is the deep inguinal ring. So throughout its extent, the posterior wall is formed by fascia transversalis, deep to that extraperitoneal connective tissue, and still deeper to that by the parietal layer of the peritoneum. And here the medial part of it is formed by conjoint tendon, which is already explained how it is forming. And the medialmost end is even contributed by the reflected part of the inguinal ligament. Hope all of you remember it. I have explained it earlier itself. It's an extension of the inguinal ligament from the medial end towards the linea alba. And one more ligament you can see here. This is the interfoveolar ligament. This is nothing but a condensation of the fascia transversalis near the medial edge of the deep inguinal ring. Floor of the inguinal canal is formed by the inguinal ligament and medially by the lacunar ligament. So you can understand it very clearly in this sagittal section. See, this is the external oblique aponeurosis muscle and at the lower end it is folding backwards to form the inguinal ligament. So this grooved surface of the inguinal ligament is forming the floor of the inguinal canal, and medial end it is formed by the lacunar ligament, which is also explained. We'll see the boundaries of inguinal canal now with the real images. This is the inguinal canal and we'll see the structures which are forming the anterior wall. This is the skin. Deep to that yellow color this is the superficial fascia, and what you're seeing here, this is the external oblique aponeurosis. And in this diagram you can see this is the skin. Deep to that you are seeing the superficial fascia, and now here this cut edge what you are seeing is the external oblique aponeurosis, and once the external oblique aponeurosis is removed, what you are seeing deep to that is the internal oblique muscle. Now you can very clearly see that internal oblique muscle is forming the anterior wall, and now you can see the fibers are arching backwards, downwards and medially, now forming the conjoint tendon along with the transverse abdominis muscle, and it forms the posterior wall too. And here clearly you can see the spermatic cord coming out from the superficial inguinal ring. This diagram explains the triple relation of the internal oblique muscle to the inguinal canal. This is the inguinal ligament, and here this is the inguinal canal, and you can see the spermatic cord in it. And this is the internal oblique arising from the inguinal ligament, and this is transverse abdominis arising from the inguinal ligament. And you can see both the inguinal fibers are arching backwards, downwards and medially, and they are going to join together to form the conjoint tendon, which will be getting inserted to the pubic crest and the medial end of the pecten pubis. Thus, this internal oblique muscle is forming the anterior wall, then it is forming the roof, then the conjoint tendon is forming the posterior wall of the inguinal canal. Now, we'll see the posterior wall of the inguinal canal. Now, here, this is the fascia transversalis, and you can see the deep inguinal ring in it, and you can see the spermatic cord coming through it, and this is the external oblique abdominis muscle, and this is its aponeurosis, and here you can see the superficial inguinal ring. So this is the inguinal canal which is extending from deep inguinal ring to the superficial inguinal ring. Now you can clearly see its posterior wall. Throughout its extent it is formed by fascia transversalis, and behind that this yellow colored fatty tissue, this is the extraperitoneal connective tissue, and deep to that what you are seeing is the peritoneum. And at the medial end of the posterior wall, you can see here it is formed by the conjoint tendon. Now you can see it here, this is the internal oblique muscle, and behind that is the transverse abdominis muscle. You can see that the fibers from it are arching over the inguinal canal. This is the inguinal canal, and these fibers are arching over it and forming the roof, and you can clearly see both the fibers are joining together medially, and it is forming the conjoint tendon, and it is lying posterior to the inguinal canal, forming the posterior wall medially. And one more structure which is forming the posterior wall at the medial end is the reflected part of the inguinal ligament. So you can see here this is the external oblique aponeurosis, and you can see here it is folding on itself backwards to form the inguinal ligament. So this is the inguinal ligament, and from the medial end of the inguinal ligament a part of it is extending upwards towards the linea alba, which is situated between the two rectus abdominis muscle, and this part will be passing deep to the spermatic cord, and that means deep to the superficial inguinal ring and superficial to the conjoint tendon. Protrusion of abdominal viscera through inguinal canal is called as inguinal hernia, and small intestine is the most commonly herniated abdominal viscera. Inguinal hernia is of two types. One is a direct hernia and the other one is an indirect hernia. If the herniation occurs through the deep inguinal ring, it is called as the indirect hernia, and if the herniation occurs through the posterior wall of the inguinal canal, it is called as the direct hernia. Now just see this small triangle, and direct hernia will always occur through this small triangular area and enter the posterior wall and reach the inguinal canal, and this area is called as the Hasselbecks triangle. This image shows the main two types of inguinal hernia, that is indirect and direct inguinal hernia. This is the indirect inguinal hernia, and you can see the intestinal loop is entering the inguinal canal through the deep inguinal ring, and in this direct inguinal hernia the loop of small intestine is entering the inguinal canal through the posterior wall of the inguinal canal. Further details of the inguinal hernia, its differences and PBL question of the same will be discussed by Dr. Ramakrishnan sir. The weakest area in the anterior abdominal wall through which direct inguinal hernia commonly occurs is called as the Hasselbecks triangle. And this is the anterior view of the Hasselbecks triangle, and this is the view of the Hasselbecks triangle from the interior of the abdominal cavity. Now you can clearly see this small triangle is the Hasselbecks triangle, or else it is called as the inguinal triangle. Now we will see the boundaries of the Hasselbecks triangle. This is the Hasselbecks triangle. It is bounded medially by the lateral border of the rectus abdominis and laterally by the inferior epigastric vessels and inferiorly by the inguinal ligament. Hasselbecks triangle can be again divided into a medial part and a lateral part by obliterated umbilical artery. So herniation occurring through the lateral part will be called as a direct lateral hernia, and herniation occurring through the medial part will be called as a direct medial hernia. Thank you and have a nice day.